Palliative care kind of started out in the bigger cities in the Northeast. Physicians were seeing that there were patients who were not qualifying for hospice just due to the government regulations that surround the hospice benefit. But they were seeing these patients with very serious illnesses and all the issues that they were having to deal with, and just recognize a need out there for some type of medicine that could address those issues.
Palliation has to do with comfort, and it comes from a word that has its root in the idea of a child being comforted on a cold night by its mother wrapping a warm blanket around it. It has to do with a covering or a comforting process.
The first question is, what is palliative care and how can you help us? And so we explained to them that our role is to focus on their comfort, in their educational level, and help them understand what's really going on.
These conversations that we're having, these issues that we're addressing, are very time demanding. And so I tell the patients and families, we're going to sit with you. We're going to be here with you on this journey, and we're going to give you our time. And we're going to talk to you about what you want, figure out what's important to you, and spend some time making sure we accomplish what you want. That's the core of palliative care, is that it truly is meant to be delivered as an interdisciplinary team. I'm Chad Farmer, and I am the medical director of the palliative care team at St. Joseph's Hospital.
My name is Annette Ramos, and I'm a social worker on the palliative care team at St. Joseph's Hospital. I majored in clinical therapy. When I moved here, I started working for the Children's Hospital at St. Joseph's Hospital in the intensive care unit and the cardiac intensive care unit. And in those units, I encountered a lot of end-of-life issues and a lot of families that were going through a lot of difficulties that absolutely needed a lot of support. So that pretty much qualifies me through those experiences that I've had for end-of-life.
My name is April Rao Gallo. I'm a certified nurse practitioner. Some people don't know exactly what a nurse practitioner does in the state of Florida. Nurse practitioners are considered physician extenders. The addition of a nurse practitioner in the palliative care team allows us to expand our medical services to the patients.
My name is George Francis, and I am the palliative care chaplain here at St. Joe's. I have a Master of Divinity degree. I've worked in this field for almost 34 years. As a palliative care chaplain, one of the things that makes what I do very different from a local minister, priest, rabbi, imam, something like that, is that we are normally familiar with the basic rituals, the basic end-of-life rituals of all the major faiths, and we try to utilize those rituals to help people connect with their higher power and transcend the limits of their physical illness.
One of the first questions almost everybody has, patients and families, is how much time? I mean, they really want to kind of begin to understand the time frame you're talking about, and that's always a challenge when you're working with patients and families.
We ask them to bring their loved ones and friends that also have questions, so we can create a forum of comfort and understanding for them where they feel safe in asking what they need to ask to understand the disease processes and what's happening.
Well, basically, when we get a patient in, one of the main priorities for us is to find out if there is a proxy or healthcare surrogate, are there advance directives, a living will on the chart, and that's just really important because we want to make sure that people's wishes are being honored.
Dad has been ill for quite some time, but he never revealed to us until last night that he was terminally ill and did not have long to live, and they were in a sense of just absolute shock.
A question that I ask help for is when they say, well, why is this happening to me?
I'm not normally brought in after the doctor has discussed the diagnosis and the prognosis with the patient and their family. At that point, especially if the patient and family know clearly that their loved one has a terminal prognosis, I come in to help the family deal with that based on their religious and cultural and spiritual needs.
I would say maybe about 70% of our patients are incapacitated. They can't think for themselves. They can't make their own decisions. So really a significant part of our work when we get a consult is with the families.
But working with the family is basically understanding the family dynamics. And every family is different. And some family members, again, they can readily accept disease and the death process. And other families are not there. They're not accepting that. And so helping them get through that process is the most important thing.
And sometimes they'll ask us, can you please just talk to my family and let them know how I'm feeling? Many times the family members are concerned that the palliative care team or one of the physicians might tell the patient that they're terminal or that they have an illness that can't be cured. And families become very anxious with their loved ones receiving that information. And us facilitating that conversation between the family and the patient becomes a pivotal role in how it's perceived. And sometimes we're able to help facilitate that in a manner where it becomes a very embracing time for them, where they can embrace what's happening and then are able to talk about it. And that becomes the hardest thing for families and patients sometimes, is actually talking about what's happening and what's going on.
Mm-hmm. Yeah, that comes up a lot, and that we have had difficult situations, unfortunately, with families that differ, and they're not able to come to a consensus in regards to what decisions they want to make for their loved ones at end of life. One of the things that I always remind families is the whole power that they have together as a family unit. And the fact is that that mother or that father would want those siblings to have each other, especially when their parents are not there.
I deal with it usually at a grassroots level. Several years ago, Ira Bayek, who's the head of the National Hospice Organization, wrote a little book entitled The 4 Things That Matter Most. And in it, he observed over a 30-year career what patients seem to want, need, and ask for the most in a terminal situation. And he says it boils down to 4 basic things that if you can help the patient and their family deal with these 4 basic things, you'll have done a world of good. Here's what they are. I forgive you. Please forgive me. I love you. And goodbye.